Okay, I think we would begin. Good afternoon once more to everyone. Thank you for joining us. I can't believe we're already at our 7th week of running this weekly conferences. I want to thank you all for taking time to join us. My name is Aray Obenson. I'm President and CEO of the International Institute. And today we're going to give you further updates, but also spend some time talking about the resettlement path, so to speak. We have in the last few weeks covered the question of what resettlement entails, and we spoke about housing, and last week we did speak about education, and this week we really want to focus on something that we see that's going to be an obvious conversation, or it's already an obvious conversation. It's really health and mental health and what happens in the process. The agenda, as is projected on the screen, is going to cover. First, we'll have the weekly update as we've traditionally done, and then we'll focus on health and mental health services, and then we'll open it for question and answers. Like we've said every week, this is a highly dynamic situation. Circumstances change by the day, by the hour, by the week, and we've had to be dealing with that. We have sometimes had to hurry and wait, and sometimes we've had to go into overdrive to be able to make things work. But the most important thing that has come out of all of this has been the collaboration that we're seeing within the community, and how the community has come together to make this moment, to help this community live up to the moment. And that has been great, and we're truly grateful for that. And we hope that this weekly conversations fosters that collaboration, and that we can build on it by sharing as much information about our work, so that each one of you stakeholders in this community can clearly see how your contribution can be valuable for us to build a more welcoming and inclusive community. With that, I will turn this over to Senior Vice President for programs here at the International Institute, Blake Hamilton.
Thanks, Aray, and hello, everyone. Welcome again to our 7th. For this week's updates, we have some varied news to share. And one thing that I actually left off the slide that I want to make sure that we cover today is the fact that on November 1st, we were notified by the Centers for Medicare and Medicaid Services that as of November 1st, Afghan evacuees arriving in the United States will be eligible for health insurance, which includes Medicaid, CHIP, access to the marketplace, and refugee medical assistance. And refugee medical assistance is a program administered by the Office of Refugee Resettlement and the Administration of Children and Families, which is administered to us locally by the Missouri Office of Refugee Administration. So we await word on any sort of expansion of that program that will be available to us. But this is very good news that addresses some of our, firmly, and answers some of our most pressing questions related to health access, and I think will help and sort of inform our conversation a little bit later today. In addition to that bit of very good news, I did want to mention that we did receive word from PRM, which is Population, Refugee and Migration. What we understand now is that Afghan resettlement geographically in the United States, we've talked about before, has been uneven, where some places have been quite oversubscribed, like Sacramento in Northern Virginia, where many people have family members or are requesting for relocation to be made there. But what we understand now is that they are very much limiting access to these locations based on the volume that these areas have already seen, volume of arrivals. So what we know is that areas like St. Louis that have yet to see a large number of the arrivals that we've expected actually come to the region, we'll start to see more. But there's a sort of another side to this, which is out migration, because we will be resettling then in our region folks who have family members in other parts of the country. They might have been denied resettlement into those areas based off of an overloading of the system in Northern Virginia and Northern California, which couldn't handle resettlement for them. So they could be arriving here in some cases with a very strong desire to move once able to. And so that kind of changes our path for folks in terms of the volume of services that we can provide still exists, but there could be a strong desire for folks to move out of our region once arriving, should they have been deferred to St. Louis as a result of oversubscription in these two areas. So it's another factor for us as we consider, how do we create a more welcoming environment, the most welcoming environment possible to convince people that they are giving the best opportunity here. Of course, the draw of family is very difficult to compete with, and we want folks to be making decisions that are the best for themselves and their families, and not just for our region. However, I think this underscores the need for us to have an organized, welcoming community that can support folks upon arrival, to make a compelling argument for St. Louis as being the location that has the best chance of helping folks and their families achieve their dreams. The next item here is pertaining to resettlement. And so here we're talking about the course of refugee resettlement. Or pardon me, here we're talking about Afghan resettlement. The volume of individuals who are currently on bases, whether domestically or abroad, is such that they say if they, starting this week, they would have to be resettling about 3,900 folks every week between now and the end of February to actually clear out the backlog of folks that are on military bases here and abroad. Their calculation, their announcement of this is the implication that they will be attempting to move about 4,000 people a week off of these bases and around the United States and resettling in communities like St. Louis, and that their goal at this point still is to wrap up Afghan resettlement by the 15th of February. And so for us, we've seen very few arrivals resettled over the course of this period. So every week that goes by where we see fewer, we know now that the intent is still to reach this February 15th deadline for getting everybody relocated. We know that every subsequent week has the potential that even more folks will be arriving. And so I think the numbers that we shared at the beginning of this was that we were expecting possibly up to about 50 a week through the course of the resettlement period. But given the low volume of arrivals that we've seen to this point, that number goes up quite significantly on a weekly average, based off of this projection. And this is really just a note about timing and the fact that we have an uneven program right now in terms of oversubscription in some areas and under allocation in others that they expect to be working out over the course of the next few weeks here. May not seem like it, but February 15th is right around the corner. So we are fully expecting a very robust program between now and then. The next bullet point here is related to general refugee resettlement. And PRM likewise is putting a moratorium on refugee arrivals, they're saying, through January 15th, though there are limited exceptions. And we have actually had our national agency reach out to us this week to ask what our capacity is to resettle refugees during this period, because their intent is obviously to limit overall refugee resettlement while they expect this Afghan resettlement to be very busy. But the fact of the matter is there are still people who are in desperate need for resettlement with acute health needs that they will be pushing through the process for resettlement still, despite this moratorium. And so our national agency reached out to us this week to ask how many folks could we reasonably resettle during this period. And Ariel Burgess, our director of resettlement, reached back out to say the full allotment, 300 we could accept, during this period. We do not anticipate a need to adhere to this moratorium at present, as we're not seeing a lot of Afghan arrivals. We did ask that there be some temporary moratoriums around the holidays where staffing is difficult. We want to honor people's commitments to their families around this time of year. We want to make sure that we are available for any refugees who are able to come into the community in addition to Afghans that are eligible for resettlement. So while the national program is expecting to see a downturn, we have indicated our capacity as a region to continue and welcome refugees during Afghan resettlement. And the last bullet point here is looking ahead. We mentioned in our call last week that the refugee resettlement year has been extended to a fifth quarter, a fifth, if you will. And during this period, we're still adhering to the previous fiscal year's cap numbers and the locations where refugees will be coming from. What we've heard is that the United Nations High Commission for Refugees is looking at additional groups for resettlement in the upcoming in the upcoming resettlement year, which for us will begin in January. And they are looking at resettling groups in particular from Nicaragua, Venezuela, and South Sudan. And these were not groups that were largely allocated under previous reports. So the mention of these groups gives us thought that we will be seeing folks arriving from these communities in the next fiscal year when that kicks off at the beginning of January, which differs in some ways from the folks that we have been seeing. And to the extent that St. Louis will receive, in particular, refugees from these countries, we don't really know as of yet. When we submitted our capacity statements, last time around, these groups were very small, as they're a very small portion of the overall resettlement system. But if we do start to see rising numbers of folks from Nicaragua, Venezuela, and South Sudan arriving through resettlement, we will, of course, be increasing our commitment for resettlement for members of these groups. Additionally, our annual capacity statement is coming up again in January, where we set out our region's capacity for refugee resettlement. And we will, of course, be taking these groups into consideration and including them in our upcoming capacity statements as well. And Beverly asked, where are we with Haiti? That's a broad question, but Haiti is not a group here that was identified through UNHCR in this call where this information was released. But I think we can expect that there will be additional allocation by the UN's designation for refugees. However, that does not necessarily intersect with the US's commitment for refugee numbers. So we are still engaging in advocacy around increasing numbers for arrivals from Haiti throughout the program, whether that's through refugee resettlement or other means, such as humanitarian parole or such as temporary protected status. But those are what we talk about when we talk about UNHCR, are sort of international designations for refugee groups. Still, that gets filtered through our country's commitment for refugees from certain regions. So talk about American commitment towards Haiti extends well beyond refugee resettlement, but is something that there is a large amount of advocacy for at a national level. And we would encourage anybody who's interested in learning more about that advocacy to get connected with us, and we can connect you to our national partners who are doing what they can to bring this very important attention, or very important issue to the attention of legislators.
Thank you. Thank you very much, Blake, for that update. Are there any other questions? Any questions for Blake with reference to the update that has, for us, with reference to the update that has just been provided? Seeing none, we'll still have an opportunity to take questions at the end of the session. We're going to move on to item 3 on the agenda here, and that item 3 on the agenda has to do with what we mentioned here, social health and mental health services. And I'm going to invite our Vice President for Resettlement and Director of our Social Work Department, Ariel and Rosie, to lead this part of the meeting.
Hello, everybody. This is Ariel. I'm glad that everybody's here. It's really great to see everybody. I'm going to kind of kick this segment off by talking about what we provide for health screening in resettlement or for our resettled clients. So basically, in order to be a resettlement agency, there is a list of core services that you have to be able to comply with. And one of those core services is what we call health screenings. So health screenings need to be done within the first 30 days of arrival to St. Louis for refugees that are sponsored by the Institute. And I make that distinction because for individuals who are walk-ins or are APA, there's slightly different criteria for their health screening. So for right now, I'm just talking about refugee resettlement clients. The Institute partners with the city's Department of Health, with the State Refugee Health Coordinator, and also with Affinia Healthcare to provide health screening. And health screening is a two-step process. The Department of Health and Affinia will do segments of this, but basically health screening includes tuberculosis testing, parasitic infection testing, HIV testing, lead testing for children 18 and under. And then also the second part is the physical exam that is done with Affinia Healthcare and typically Dr. Chris Prater. That's the sort of the kickoff to their healthcare that refugees are required to have. And from that, then they are enrolled into benefits for healthcare. So they might be in Medicaid, they might be in medical assistance for families, they might apply and be eligible for refugee care assistance, refugee medical assistance. And so all of those then follow up on whatever the health screenings typically found. Now, for health screenings for walk-ins, so when I say walk-ins, I'm talking about Afghan parolees who were on a US base and they voluntarily left the base and they're now walking into resettlement sites. So they're walking into the Institute. The difficulty that we have with walk-ins is that their paperwork is not consistent. So some of the family members might have what we call I-94s. They might have employment authorization cards. A couple of weeks ago, I had a walk-in case that had Social Security cards, whereas no other walk-in case had that. So there's no consistency in the paperwork. And this makes a difference for applying for medical benefits. While they may be eligible for medical benefits, FSD needs to see A numbers or alien numbers or Social Security numbers or I-94s or something that verifies that they're legally in the United States and in Missouri. So that's been an issue that we've had and are working with individually because each case is different as to what is needed and how we can get that documentation. You should know that walk-ins are not currently eligible for refugee resettlement, meaning that when they walk in, we have to apply for refugee resettlement services and funds to be able to work with these clients. It's generally taking a month, maybe a little bit longer than a month for individuals to get approved for refugee resettlement. Once they're approved for refugee resettlement, then we can provide services to them, such as health screening or benefit applications or Social Security card applications and the like. In the meantime, until they're approved, we are providing them with information as to what's in the community and services that they might be eligible for here at the International Institute. We do keep them open, and we are providing them with donated gift cards and donated items, household furnishings and clothing and whatnot. We're still in touch with those clients and trying to assist them with their identified needs until they are approved for refugee resettlement. Once they're approved for refugee resettlement, they're then what we call an APA program client, so an Afghan parolee applicant. And then they're eligible for all of their refugee resettlement services, including health screening. Any questions about the very beginning of health screening and the services of health screening? Okay, so what you should have heard is right now for individuals who are what we call walk-ins that have not been approved for refugee resettlement yet, they are not able to get health screenings. It is a requirement that they do comply and get health screening within, I believe it's the first year of arrival, so that that would allow them to get health screening once they're approved for resettlement, which is hopefully about a month or a little bit longer after they've arrived to St. Louis. I know of one case that is going to Affinia and has already scheduled medical appointments for the family. It's a family of 8. They do have a community organization working with them and has helped them navigate that. So that is another way that Afghan parolee walk-ins can get services. I will say that the community organization has been working very closely with the Institute so that we can provide them with referrals and resources and support to where the individuals should go to engage in healthcare. I'm going to stop there and turn it over to Rosie, who is going to talk a bit about emotional and mental health needs, in addition to medical needs of our clients while they're in refugee resettlement and after.
Thank you, Ariel. Good afternoon, everyone. Thank you, Ariel, for your overview of health screening and those first touch health services. It's really important. I'm Rosie Lang. I'm the Director of Social Work here at the International Institute. And just very briefly, our team provides services predominantly to those who have the most barriers or the most at risk of our at-risk populations. And so very broadly, we focus on capacity building both through micro-level direct practice, intensive case management with clients, as well as really serving as a resource to bolster the broader community's ability to better serve our immigrants and refugees, and of course, through the advocacy lens through which we do our work. If we go to the next slide, just very quickly, background, we come from a philosophy that emphasizes clients' right to self-determination and making choices, and operate from a trauma-informed, strengths-based model, which we hope helps us serve as a driver for social justice. A lot of the work that we do is planting seeds and cultivating capacity and growth. Thanks, Armenia, for working through those animations. If we go to the next slide here, in terms of our intensive case management services, you can see here on the slide a very quick guide to our services and eligibility. Afghan parolees are eligible for our intensive case management programming that extends beyond that initial resettlement period. And that's something that's really important to know. We can provide some longer term intensive case management services. The challenge that we're finding, and I think we're continuing to work to address with funding entities, is guidance on actual enrollment into these programs. The takeaway from our service is really that we strive to walk with our clients in navigating some of these very, very complex medical systems that they face upon arrival. And I can say, having grown up most of my life in the United States, these are complex systems for me. And we know that clients do struggle to navigate these systems at times independently. And so in the initial phase of case management, we're really focused on crisis stabilization for some very complex medical needs. Individuals who have very complex trauma histories, developmental or intellectual disabilities, as well as intimate partner violence, which can of course have some health and mental health consequences as well. And so we work to assist folks in accessing services in order to support their well-being. Now, historically, a very large component of the case management services that we've offered has been geared towards individuals with very significant physical and behavioral health needs, right? The most at risk of our at-risk populations. And we do quite a bit of healthcare navigation. So you might see our social workers and client advocates walking alongside clients in primary care medicine offices, specialty care office visits like oncology or cardiology, or in benefits offices, helping advocate to get the benefits that they're eligible for. You might also see us in family homes working to ensure that folks are, indeed receiving their medication or understand how to take it, or maybe we're in the grocery store pharmacy teaching somebody how to pick it up. As the physical health issues stabilize, we shift into more intensive coaching and building those health literacy skill sets so that folks can have success in navigating systems on their own. Now, in traditional refugee resettlement, we often are able to flag cases ahead of time. In which maybe we have some pre-existing overseas biodata that shows us that there's a significant health issue, and we can kind of, even before somebody arrives, jump on it and start scheduling appointments or working the systems to get individuals connected. The challenge with some of these Afghan parolee walk-ins is that we don't really have a lot of information, and so getting them connected to us for assessment so that we can identify some of these needs before they turn into crisis even is really imperative. And that's a focus of our efforts now, is really ensuring connectivity to these healthcare case management services. If we go to the next slide, I'll touch briefly on some of our behavioral health services that really work hand in hand with our case management team. We do offer screenings for behavioral health utilizing the Refugee Health Screener 13, which is one of the few tools that are normed for our populations. And we're looking at ways to expand capacity in this area because we really, we are cognizant that the behavioral health needs that we're going to be seeing are going to be coming in at a level that has been somewhat unprecedented for us. And so we are working really hard to try and expand capacity so that we can engage in more targeted early intervention for this group, which I'll talk about in a bit, is really presenting with some very acute trauma reactions, understandably so. Dependent on client need and readiness to engage in service, we also do offer individual therapy services. This is for adults at this time in a variety of modalities, including EMDR, acceptance and commitment-based therapy. We do quite a bit of mindfulness and relaxation training as a way to build up some more adaptive coping skills for folks who are experiencing acute trauma. And we're able to offer these services in many different places, dependent on what the client needs and what the client feels will be most useful for them. So that could be in their home, it could be in our office at the International Institute, or via a telehealth platform. And then moving on to the next slide, I wanted to touch a little bit on what we're seeing. And it's really important to note that trends are still emerging. So I'll talk about what we're seeing and what we've historically seen with the population, as well as what we're hearing about from the military bases. But this is still a very active situation, and I anticipate we'll be learning quite a bit more in the next 5 months as arrivals start to come in greater numbers. but we are seeing a lot of acute trauma reactions. So folks who are having a lot of emotional dysregulation, or in turn, numbing and dissociation. At times, this presents as a lot of anxiety and hyperarousal, which of course is very understandable. And it also means that they are often coming to their worker or their intake assessment person in crisis and very activated. And so we're working with the team on building processes and procedures to help our team members deal with that as well. We have also seen historically high rates of self-harm, inclusive of cutting and other forms of self-harm, as well as self-directed violence. And so the parasuicidal behavior you can see here mentioned, cutting and things of that nature. We also have a lot of suicidal ideation, both with and without intent. And most of the time, what we've seen historically is without intent to actually engage in suicidal behavior. But again, trends remain to be seen. We also have a lot of individuals, and this is really important to note, that simply because they have left the crisis situation overseas, it does not mean that they are not still in active crisis after arrival. So we are seeing, again, individuals who are experiencing domestic violence or intimate partner violence and the trauma that is associated with that. There's, of course, trauma related to adjustment and having spent time on a military base as well. And then just simply the ongoing nature of the crisis. Something we didn't see as much 10, 15 years ago was the impact of technology on trauma. What we're seeing now is that individuals are still very much connected at times to family members overseas and are receiving a lot of vicarious trauma from family members. And they're not just hearing it, they're getting sent videos, getting sent recordings that are very, very traumatizing and make healing after coming to the United States a challenge. It is difficult right now to determine the physical health trends that we're seeing amongst this population. And so the primary need that we are working on is just access to really solid and timely primary care appointments. Go to the final slide here. So what are the needs based on the conversations that we've just had? Essentially, I want to re-emphasize early intervention screening and assessment so that we can have some conversations with individuals before they may reach an even higher level of crisis. Or for those who are not feeling in active crisis, we want to offer services and support before that comes to be. We also see the need for additional and ongoing psychosocial support and behavioral health literacy, as well as case management that is geared both towards behavioral health and longer term adjustment needs, right, that are really stressful and exacerbate some of the traumatic stress that our clients are experiencing. And then finally, access to primary care is what we're looking at this time. And with that, I will end and turn it back over to Ray.
Yeah, thank you very much, Rosie, and thank you, Ariel, for sharing that information on health and mental health services that are provided here at the International Institute. At this point, I'm going to open this up for any just open forum question and answers here. I see a question from Stanish Stanley, and I think this is directed towards Ariel with reference to a health screening on November 6th. Ariel, the question is in the...
I saw the question and I just responded.
Okay.
I think it would be a good resource possibly for what we call our walk-in parolees. However, keep in mind that they will have to show proof to upgrade their status from parolee to asylee, that they've had a physical exam, that they've had lead screening, that they've had HIV screening, gonorrhea, all the varieties of screening. So I think this would be a good possibility for people who want to engage in medical care. However, once they become approved for resettlement, we'll most probably have to do those specific screenings all over again and get it into the system as being done.
Thank you. And Ariel, should they just reach out to you if there are any providers that want to support this work?
Really, health screenings, we work very, very closely with the State Refugee Health Coordinator, Chelsea Boutress. And all of that, they have to be contracted with her in order to do health screenings. So they can either they can contact myself, and I will make the introduction with Chelsea to see if she can open up the panel.
Okay, thank you very much for that. Any other questions for Ariel or Rosie or Blake? Good. Seeing none, Blake, is there any other information that we need to share this week?
I would just mention that we are putting together 2 other community meetings. One centered on immigration and legal services that'll be hosted by the MICA Project coming up next week, November 10th. And I believe we currently now have a date for our first meeting for a cohort around education needs for folks coming in. I know Dr. Gonzalez has been a part of that as well. So I want to just shout out those and say if anybody is interested in joining those, either of those, please feel free to reach out. We can make sure you get an invitation to join those conversations as they come up.
Well, with that, thank you very much for being here today. I know that this list of organizations continue to grow. There are several organizations that reached out to us during the week to be part of this conversation. We hope that we're going to continue with this as long as necessary as we deal with the Afghan arrival circumstances. But it's been truly remarkable to have your support and participation. And we will be back next week with further updates as things change on the ground. But again, thank you very much for your time, for joining us this afternoon. And we'll see you next week.